it to us afterwards.
I will try my best to figure out how to do that.
So this would be really good to kind of just remind ourselves, you know, I'm not very good at taking notes.
Yeah, so the other question, Rob and Ralitsa, that Jackie had was, she was saying that as the government announced that some people may get the flu and COVID booster jab at the same time, by having one jab in each arm. Now, is it okay for people like Jackie, who is affected by the condition in her arm? Is it safe to do that? Because of obviously the general makeup of her veins and nerves, etc., is different than a normal arm. So she's asking, with her veins being larger, could this affect how the vaccine works or carried or absorbed into her body at all?
So that's another really good question. So I don't think there's anything about PROS which is going to change how the vaccines work. This is from the point of view of getting a good result. But with any condition where there are changes in growth or with the veins or with the lymphatic vessels that drain tissue fluid from an arm, you just anatomical point of view, because getting a vaccination is nearly always 100% safe. But let's say just occasionally you had a little infection at the injection site or something like that. Usually you'll just shrug that off. But if, let's say you had an arm which had a problem with the lymphatic vessels and tended towards being swollen and that sort of thing, then you wouldn't want to risk an extra complication for no reason in that arm. So my answer is it's really about anatomy. There's no reason why the vaccine won't work. But if you have a choice of sites, you're really probably best to choose the most normal site that you can. But no reason to think that injecting it into a site with extra fat growth or muscle growth or even some big veins actually will be a problem. So remember, the vaccinations go into the muscle normally. So.
Okay, thank you.
Okay, the next question we have is from Lucy. Lucy, do you want to ask it or do you want me to do so?
Yeah, I can ask it. Hi, we've got a little girl called Lily who is now 18 months, and she has a diagnosis. Yeah, she has the PIK3CA, but probably doesn't fit into any specific category. So one side of her face is affected. So we just wondered, when she's older, what kind of effect we might be able to see with surgery, and do you think there's any sort of rationale for combining the medications that there are now with surgery to kind of prevent overgrowth and it coming back?
So this is I mean, what's the overgrown tissue? Is that a mixture of fat and blood vessels and lymphatic vessels and those sorts of things?
It's on her cheek, it's just fat, but also bone as well.
Okay. Because certainly she may not exactly fit a category, but as you probably know, there are a lot of people with quite a lot of overgrowth affecting the face. And so the answer is everything, always with this condition, everybody is different. Even if you've got the same gene change, the very same mutation, two people can look very different depending on exactly where it is. And both surgery is certainly always important, and so you want to make sure that you're being seen as she grows up by a really good, sensible surgeon, and that means somebody who's done that sort of operation before. And you want somebody who, frankly, in my opinion, for any sort of surgery, you want a surgeon who's old enough to be wise and not so young that they're trying to prove themselves all the time by doing everything. You want a surgeon who doesn't really want to operate, but is happy to operate when the time comes. So I think having a good, sensible person that looks individually at the anatomy and does the right thing at the right time is very important. Now, might some of the medical treatments around be helpful? Yes, they might. So you probably know a bit about this, and you probably heard that alpelisib is the tablet that people are talking about. And they have continued to give that to people with PROS of a variety of different types. It's still not yet a proper trial. There was a lot of excitement when the first paper came out saying there were amazing reductions, but what always happens in this situation is when you just report a series of stories like that, it sort of exaggerates the effect. So now they've told the world about more patients, and there are still good effects, not quite as big as first reported, And the long-awaited trial, it's a big, you know, it's great that the company is very keen, is about to start, but that's a sort of 5-6 year timescale before we got full answers, and that will give us the ultimate answer. But my best estimate from everything I've seen at the moment, and this is a sort of a comment to everybody here, I think this alpelisib is definitely doing some good. And it seems to be doing some good in a decent proportion of patients, you know, maybe 30 or 40% is what I last heard, in actually shrinking down bits of overgrowth. You have to assume that the things that it might shrink will be the soft bits, not the hard bits, if you see what I mean. It's just not sensible to imagine that a bone is going to shrink, but fat and everything else might. But also what I was quite encouraged by with the information that was released recently was, even though 30, I think it was 38, nearly 40% of patients reported that their overgrowth shrunk, there was a much bigger effect in terms of quality of life than what people reported. You still have to be careful with that, because anybody who's taking a new treatment really wants it to work and gets quite excited. So you tend to get over-reporting of good things. But to cut a long story short, yes, I think there will be a place. And the other thing to mention is that some of the people in the studies so far have been very young, and everything looks very encouraging about the side effects and the safety, even in young children. And that's crucially important. It's not without side effects, but it looks pretty safe. So yes, I think it's a good option, and I don't think it's going to cure PROS, but I can absolutely imagine that some combination of the two could be useful as time goes by. The big question at the moment really is how you would get access to alpelisib. Let's say the situation was much more severe and you really wanted it urgently. So the situation still is that the company, I should say also, you know, it's a very expensive medicine. It's quite a simple sort of drug if you look at the chemical in it, but it costs about £200,000 a year. Just that shouldn't be important for anybody that needs to have it in the NHS, but just to give you an idea of why people are so cautious to wait for the right evidence. But the company still makes it available on what they call a compassionate use basis. So if you have a doctor that makes the case to them for why it's a severe situation or an emergency, you can still get hold of it. So there is a way to do that, but again, from what you say, that might be more difficult a case to make at the moment. So I think it's really good news. I think it's coming along well, and I think there will be tablets as well as the right type of surgery in future. And I think it's a good option now for anybody who's having really, really severe problems. If you aren't having severe problems, I think it's probably going to be difficult to get hold of it unless you get into one of the clinical trials. So a really, really long answer, I'm afraid, but hopefully there's some things in there that will help.
No, that's great. And we so we're with Nadeem Saeed at Great Ormond Street, and his opinion is that we should wait until she's about 12, I think, before we do any operation. So hopefully by then it'll be generic and it'll cost nothing, and we can.
Yeah, I mean, but I think as long as it works, you don't need to worry about the cost. That's the great thing about an NHS. It will be the size of the benefits and everything else will be evaluated and it'll be approved. So it's not a worry for you. But I think being at Great Ormond Street is great, just because in this country they have so many people with these types of problems, and so you have the confidence that you're being followed by somebody who's seen this a lot as well. So.
Yeah.
One follow-up is, taking drugs aside, if you're able to reduce or remove fat through surgery from, say, Lily's cheek, what's the tendency of overgrowth to reoccur once the fat tissue's been removed? So experience is that, I mean, fat is a tissue that's very good at expanding in all of us. As you know, if you eat too much, that's why you can go from being thin to being very, very fat. It's a really good tissue at doing that. And experience is that if you take away extra tissue, which is very fatty, it probably will grow back. Now, I've heard it said a few times that there's a sort of theoretical worry around that you might poke it and anger it, and it might even grow back faster. But I must say, in my own experience and speaking to experts around the world, I've never seen any actual evidence for that. So most times when you what they call debulk and take away fatty tissue, there is a slow rate of regrowth afterwards. In particular during the natural growing years. In most people, that seems to slow down a lot once the natural growing years are finished. But you know,
Why some people do carry on growing in adult life and others don't, we at the moment, we don't know.
Thank you.
Thanks.
Ralitsa, is anything that you would like to add to that at all?
Not to that bit, but I think I was thrown off just when the diet question was finishing, and I thought I would follow up on something related to that. I think maybe once people are taking alpelisib, thinking about diet changes may be relevant. So that's something that is being explored in the context of cancer and alpelisib, and actually they're running clinical trials in that context. Obviously, needs to be assessed with caution, because one thing is cancer and another thing is PROS, but there might be some evidence for useful evidence on that front as well that could be relevant in this context. But that was all.
Yeah, that's a good point. So what Ralitsa is talking about specifically is that one of the side effects of alpelisib is that it can block this action of insulin that I was talking about before. And most people deal with that fine, but sometimes, especially if you have a tendency towards diabetes, that can bring diabetes out, which is high blood sugar. And also sometimes if the sugar level goes up, your body makes more insulin to try to counteract it. And there is a feeling in the cancer world that might blunt some of its effects. So yeah, so it's something which would have to be tested. But it's possible in the future that if you want to get the most out of alpelisib when you take it, it might be worthwhile changing diet or even taking another medicine with it. But that all needs testing at the moment.
Thanks, Rob. The next question is from Erin. Would you like to ask the question, or do you want me to?
Go ahead.
He was wanting to know, his main interest is to learn on progress of candidate stroke potential testing drug therapy.
Yeah, so really a lot of the things I said about alpelisib are the key points. So as soon as we and the world knew about PIK3CA changes, there were a lot of possible drugs being made by companies for everybody to think about. And some of them have been tested. So sirolimus, which Mandy knows well about and others know about too, for some particular bits of PROS seems to have some effect, especially if you have lymphatic overgrowth. But experience is that it doesn't really dramatically, in most people, doesn't really dramatically reduce the soft tissue growth. So then the next big things on the block were the molecules that actually turn off the gene itself. And there have been really two possibilities. So we started up a study with some colleagues in France of one of them, and it looked quite good at reducing overgrowth, but it caused serious side effects. And that's because that was a medicine that didn't just interfere with PIK3CA. It did something to one of the related proteins at the same time, and that's where it upset the immune system. So it just goes to show how careful you have to be with that. So that one has disappeared now. Alpelisib I've talked about a bit, and as I say, it's looking good. What we don't know yet is exactly how big the benefits are and exactly what the cons are. But the accumulating evidence is that it does good. It's good for symptoms and it's good for growth, and it will have some place. But some people will respond, some people won't.
Can I maybe add something? Can I interrupt you for a second? Maybe add to this. So two new things that have come out very recently are drugs that are actually specifically targeting a PIK3CA defect, so a mutation. So some of the most common ones, like Mandy, for instance, I know you have H1047L. So there are drugs now that are where they're trying to target specifically the 40 molecule. And obviously that's not in a clinical trial or anything yet, but it looks quite encouraging and could potentially be exciting moving forward, because some of these mutations are more common than others. But again, as Rob says, some patients will respond, some will not. But the good thing about having a more specific drug that only targets the 40 protein is that you will then avoid some of the side effects associated with targeting the PIK3CA molecule throughout the body, because that's quite important for a lot of other things than just, the overgrown tissue. But quite far off still clinical trials.
So I think there's an important point there. So I think at the level of scientific discovery, there's a lot of really exciting ideas and new things coming along. But what you want to know is when might there be a tablet that you can take which does some good. And that's why the alpelisib is looking so encouraging. It does exactly the right things. It clearly does some good in people as well. And there's actually a trial starting now, and you need to do a trial before governments will agree to pay for drug and all that sort of thing. And even from the point of somebody realizing that alpelisib might be a good drug, persuading the drug company to start using it like this and going and getting approval, you know, that's probably 10 years, to be honest, from when that medicine works. So let's say one of these new compounds, which Ralitsa is talking about, looks very exciting. Unfortunately, there are commercial realities. This is one of the things I've learned from doing this. And if this looks like a fantastic drug in cancer, let's say, then above all, the company will be desperate to make it into a cancer drug because there is a large amount of money to be made there. And while it still looks like it might be a big cancer drug, they're often a little bit unhappy to risk it in other rare conditions where stuff could happen that makes it more problematic to get approval. And I think one of the big successes of alpelisib was that a good doctor in France put a foot in the door of the company and wouldn't go away until he persuaded them to try it in PROS. And it was just the right time because it was showing some benefit in cancer, but not as much as they hoped. So they were quite keen to find something else to use the drug for. So unfortunately, there's a lot of sort of money and politics and behind which of these things get used in rare diseases. So I think in the medium term, alpelisib absolutely is the biggest show in town, and it looks good. And I expect, I expect based on everything we know that the trial will be positive. The question is how positive will it be, and then it will get a license and it will be used clinically. These other things are probably 10, 15 years down the line. I would say, and this is just an unfortunate fact of the way medicines are made. But alpelisib is good. So, and there's a lot of very ingenious scientists still trying new strategies. So I'm not trying to take away any excitement. There's lots of great stuff going on. Lots of very clever people doing very clever things. But when, as a person with PROS or somebody in the family with PROS, you read these very exciting stories, you have to work out, is this a story of a new discovery in a cell that might turn into something in 10 years' time? Or is this a study of a trial in people which might turn into something in 2 years' time? And oftentimes it's the longer time scale.
Okay, thank you both. The next question is from Christine. Christine, do you want to ask that or do you want me to?
I can ask, it's okay, thank you.
Okay.
Hi all. I have a 14 going on 15-year-old daughter with MCM. And my question is about the vaccine for cervical cancer. I'm a bit hesitant because I'm not sure how it's going to affect her given that she has MCM.
So personally, I would have no worries at all because we've got vaccines work by stimulating the immune system. So a vaccine means giving a bit of the bug that you want to fight off, so that but a harmless bit, and then the immune system recognizes that and builds its defenses against it. And so in order for a vaccine to work, your immune system has to be normal. And we have no evidence in PROS that there are any problems with the immune system in MCAP or in the other types. And in fact, most times the gene change isn't in the blood. It is sometimes an MCAP. I don't know about your own daughter, but in most times the blood system and the immune system is completely free of a mutation anyway. So so I would very strongly say that I wouldn't have any worries about that. Ralitsa has just been doing a lot of studying of everything that's known about the immune system and PIK3CA. She might want to add something else from a scientific perspective.
I would not hesitate with the vaccine either. It would be fine. Well, at least there should not be any effect of that.
And that's true. That's true of any vaccine. But and the HPV vaccine is a very good vaccine. It does a lot of good.
Okay, thank you.
I mean, in fact, you know, the point of the HPV vaccine is that it stops girls getting the virus that drives cervical cancer in the end. And you have to remember that PIK3CA is not a cancer gene in PROS, but it does help cancers to grow as well. So I could even turn it around and say that, well, if you already have one thing inside you, which is part of something that makes a cancer grow, would you then want to get HPV and drive it further? Well, no. So I think you could actually turn it around. And if you see what I mean, maybe the two things together would be unhelpful. I don't know that. I've got no evidence for that. But I think, if anything, having MCAP would make me more keen to have the vaccine than less keen.
Okay, thank you.
Now, next question is from Jet.
Hi.
Hello, sorry, I didn't see you then recognize you. I do apologize. Would you like to ask the question?
Yeah, I ask. My question is whether there are new insights into related disorders that should be screened for. Because I ask when I'm getting older, and I don't think there are much people. Yeah, my English is not so good.
We know internationally, among all the people that are interested in PROS, we know an awful lot of people with PROS, including a lot of people much older than you as well. So we can worry about that.
Oh, okay.
So the answer is no. Everybody, you know, PROS is an incredibly variable condition, as you know, and people look very different depending on which bit of the body is affected. But I have not seen any evidence of anything new or anything that we don't already know that we should be watching out for. So no, nothing that I wouldn't have told you 5 years ago. Is there anything in particular that you're worried about?
No. I've only from my level, my CYP450 doesn't work well. Do you know what I mean?
How do you know that?
They started when I got everolimus. I've had everolimus.
Okay. So for everybody else, CYP450 is one of the enzymes which breaks down certain drugs in the body.
Yeah, and it doesn't break.
Yeah, for some medicines, it determines how high your levels are. But no, there is nothing new to share that isn't known about already. I can honestly say.
Yeah. Okay. Thank you.
Is there anything that you would like to add to that, Ralitsa, at all? Okay. Our next question comes from Mia. There's two questions. Have any autoimmune disease or immune system problems been related to PIK3CA? If so, what are more popular among the PROS community? Because her daughter is suffering with a common cold still, and could it be related?
No, this is everything I said before about the immune system still applies. So I have seen no evidence from anyone with PROS or from speaking to other doctors with PROS of any immune system problems. When people with PROS get more infections, nearly always they are skin infections, and it's because they've got little blebs on the skin of lymphatics or capillaries which can get damaged and let infections in there. So in some types of PROS, if you have a lot of rashes on the skin, then you can get more infections there. But no, there's no link I've ever seen to autoimmunity or to infections with common viruses.
Can I just interrupt quickly? So my little girl, she does get colds all the time. It's really bizarre, but it always seems to go to her chest. Now she's got a lymphatic malformation on her back. Could that be why? Because she's got the lymphatic on her back, it goes to her chest more?
No, I don't think so. So when I'm talking about infections, so if you get a little cut in your skin and a bug gets in there, then the lymphatic system is very important in taking that bug to the central immune system so you can fight it. So if she had a one of the little bits of the lymphatic malformation on her back got cut and a bug got in there, you can get skin infections at that point. But that is just nothing to do with common colds which come in through the nose or anything like that. There's no reason why that would make it more prone to going to the chest. So no, I absolutely know no reason why that would be more likely.
Maybe I'll just add one thing. So PIK3CA has got a cousin called PIK3CD, and there are actually people with mutations in PIK3CD that are causing a bit of a similar defect to what you have with PIK3CA, you know, activating it. And those people actually do have increased a lot more infections. But again, it's a different molecule. So there's no evidence that PIK3CA would be causing the same defect, partly because quite often people with PROS don't have it in their immune cells. So again, it will depend how widespread the mutation is. But as Rob says, there is very little evidence that it would actually cause this type of immune defect that you could see with a quite related protein.
Could I just ask, how would I even know if she had that? Would have come up on like her genetic testing, or is it a blood test to know something like that?
So she's had a PIK3CA gene test.
She has, yeah.
Yeah.
Highly unlikely to have the other one.
So that's all you need to know, really. So the PIK3CA won't cause this problem. I think.
Okay.
It's an important point that Ralitsa makes. So there is this very related system due to a problem in a completely different gene, but one which is also a PI3 kinase gene. So if you're reading about on the internet again, it's quite possible that you might come across a condition where there's lots of nasty chest infections due to a mutation that activates PI3 kinase. And that is true, but it's a different gene and they're not the same. So I honestly can't see any link between the two.
And maybe, because I can see there's a question in the chat that is slightly related to this, whether alpelisib will increase the risk of thrombosis and infections. So when it comes to the infections, again, because alpelisib is targeting PIK3CA and not PIK3CD, it's highly unlikely to have those side effects on the immune systems that you would get with some of the previous PI3 kinase drugs that would target a broader range. But it all depends on the dose. The dose of alpelisib given in PROS is very low, so it's very, very unlikely to hit some of this other molecule that could actually affect the immune system. But in cancer, you can, in some cases, come across studies where alpelisib may also be mentioned as causing, some immune-related side effects. But that would not be the case in PROS at the dose is given.
And it's one of the most important considerations. As I said, we ran a study with French colleagues of a medicine that's very like alpelisib, but it does have a little bit of effect on exactly this other gene that we're talking about, and that's why we had to stop the study, because people did get nasty infections, and that was because the immune system was being upset. And that's why alpelisib is better, because it doesn't do that as long as you use it at the right dose. And again, that's what this trial, which is underway, will answer. It will tell us more about exactly the right dose and how high you can go while still getting the benefits before any problems start to appear.
There was Maya, you have a second question. Do you want to ask that, or do you want me to?
Yeah, I don't mind. That's absolutely fine. So are there any new findings on maintaining hand overgrowths like macrodactyly? So is there anything like, at one point our dermatologist at Great Ormond Street said about sirolimus cream, but she said that obviously she'd already had the amputation by that point, so wouldn't be a suitable candidate for it. But we just wondered if there was anything.
So I think there are some types of PROS where the idea of giving the medicine by applying it locally to the bit of the body that's affected is a really smart idea. It's a really nice idea, and I'm glad to say that people are also coming along with creams that have alpelisib in them. So first of all, they will try those in people who are who've got some blood vessel changes on the skin, which are causing things like infections, and so. I think they are trying some of those things in some parts of the world now. So it's not ready for finger overgrowth or anything like that yet, but I think that will come along. One of the problems with trying to study a finger or hand growing too big is it takes a long time before you know if you're doing any good, because what you're measuring is a slow process, if you see what I mean. So there is stuff coming along, but it's not quite ready yet. If you had a different type of problem where you were getting lots of bleeding or lots of pain, you see those things will tell you sooner whether or not you're doing good with the drug. And when anybody is considering discussing with their doctor whether or not to use a new medicine, I think that's one of my big questions. How will I know if it's doing good? Or are you going to start it and end up being on a years and years and years trying to decide? So that's one of the most important things. So coming along, but not quite ready. So.
Brilliant, thank you.
So as you can see, there's quite a few questions in chat. I don't know if you've managed to be able to read any, but Laura was asking, is there any idea if sirolimus will become licensed for PIK3CA?
I think it's probably unlikely that it's going to be licensed anytime soon. But in many ways, that's not so important because it's easy to start sirolimus. And as doctors, we quite often give medicines off license if we think there's a good reason why it will work. There are still people that use sirolimus in some bits of PROS. For example, when people have a lot of lymphatic overgrowth, and they say that works quite well. So, I don't think it's, and the process of licensing needs really formal clinical trials and lots of evidence. And I think it would be quite difficult to do those trials now, with alpelisib being the best shown time. So I don't think it will be licensed anytime soon, but I don't think that matters too much, because if there's a good enough reason to use it, it's not too difficult to get your hands on sirolimus anyway.
The problem we had is because like Jaden is nearly 18 now,
yeah.
And so the GP sort of changing the thing that we have an issue was when Jaden was a little boy, a child. Yeah. The GPs were very, very, very conscious about prescribing any medication to any child.
Yeah.
I mean, it's not so bad now he's getting into adulthood, but my question was asking mainly for the people who have children here, you know, that it is a difficult fight sometimes. Obviously, Great Ormond Street prescribed it because Great Ormond Street are more aware of children with these issues. So that's how we've got sirolimus. But yeah. I was just concerned for people with children mainly, that if the drugs are not getting licensed, unless they go to something specialist like Great Ormond Street, you know, and I think it's been quite a while since Jaden was part of the trial. Like I said, he's nearly 18 and I'm sure he was like 7 or 8.
Yeah.
So because you said it takes about 10, 15 years, I was hoping that maybe there was some sort of, you know, some sort of hope that it would be getting closer to the time kind of thing.
Yeah, so there's some important points in there. So when a doctor, I mean, I'm talking about the UK in particular, when you prescribe medicine off license, that's okay. But as the doctor, you take personal responsibility for anything that happens. And what that means is it's very rare for GPs to be happy to prescribe things off license without a hospital specialist being prepared to take responsibility for it. But I must say, in most parts of the country, you'll be able to find hospital specialists that would be quite comfortable to prescribe sirolimus. So I think the particular problems you had in Wales were really, really bad. But I think to some extent they were particular to the local doctors you had there. And I think having one of the tricky things about PROS is often people see, or children see, lots of different specialists dealing with one bit of it, and sometimes people lack one person that's kind of coordinating everything in a hospital. And I think everybody should try to have that sort of person. And then always, if you're hitting roadblocks, make sure that you get support for people who have seen this more. So my point about trials really was to go and get a license, you need some of these very formal randomized controlled trials. And the trial that we did in sirolimus is what we call a sort of pilot observational study, where what we wanted to know is sirolimus going to do a lot of good when we give it to people? And if it is, roughly how much good is it going to do, so we can go ahead and do the proper study. And the answer was it seemed to do some good in some people, but not nearly as much on average as we were hoping. And then alpelisib came along and seems to have a stronger effect. And so it would be very difficult to do another study of sirolimus at the moment. So I think nobody should be struggling not able to get something like sirolimus if they're benefit, but sometimes you need to draw in some extra support. And groups like this group can be very valuable in getting put in touch with the right people. But you know, it was terrible trouble you had. I remember that very well. I hope that won't happen again. But
Ralitsa, is there anything you'd like to add to that at all?
No.
Okay, hang on. There's another one in the chat here. Any news on whether alpelisib works on AVMs related to PROS? And that's from Paula.
So AVMs aren't very common in PROS. That's one thing I'll say. And I thought they almost never happened, but now we do know that they do sometimes happen. So an AVM for everybody else. So PROS affects blood vessels a lot, and the extra growth you can get. This is a quick tutorial for those who haven't thought about this. It can change capillaries, the tiny little blood vessels in the skin, and just give you skin marks. It can change lymphatics, a different type of vessel, which can also give you skin marks. It can give you big baggy veins. Usually it doesn't affect the arteries, the high pressure pumping blood vessels, but just occasionally it does. And that's where you get these bits of blood vessel overgrowth, which have a lot of blood flowing through them sometimes. And it's the blood vessel bits of PROS which seem to be some of the things which respond best to alpelisib. Specifically AVMs, again, we just don't have so many of those to know, but the stories I've heard have been that they do benefit. So yeah, so I think if you're having problems with AVMs, and they're not something that can be easily sorted out by a radiologist doing clever things to close off blood vessels, that's the sort of situation where talking about alpelisib would be a good thing to do.
That also actually fits with everything we know about science, the scientific aspects of arterial cells and how much they depend on the PIK3CA gene. So it's highly likely that it's going to have an effect. So just echoing what Rob was saying.
Great, thank you. That was my question. My son, who's 19, has CLOVES and PIK3CA mutation, has, since he was like 14 or 15, the AVM started popping up. It wasn't an issue when he was small. And he's had like 10 embolizations, and now, like a month ago, we started alpelisib, so let's see what happens.
So, I mean, so are you connected with the CLOVES organization in the US at all? So,
yes, I live in Brazil, but I keep in touch with them. Yes.
So they I mean, and they've helped me to understand that AVMs do occur so much in CLOVES. It's something I hadn't appreciated initially, and I know, you know, personally a lot of them have that experience. So that's a very good group to reach out to for that experience. But yeah, so I think it is useful in AVMs. That doesn't mean it also always is the cure on its own, but yes, it is useful. So.
Thank you.
Okay, the excuse me, the next question is from Rebecca. Can people with life-threatening hypoglycemia access Piqray alpelisib?
So life-threatening, can I just ask what sort of life-threatening hypoglycemia Rebecca had in mind?
Hello, hi. So our son has MCM. I think you met him about 6 years ago.
Seeing a lot of old faces in this call. It's very nice.
And it was just a question that's come out of the MCM page, asking why people with life-threatening hypoglycemia in the UK, which is related, can be related to MCM, can't access the I'll say Piqray because it's easy to say in the UK.
So I mean, so nobody can access Piqray already on the NHS, if you like. As I said, you can get it. You can get it in life-threatening situations from the company. And if hypoglycemia was being, that would be a reason to ask that compassionate use program. So but having, you know, I'm glucose problems are where I spent most of my life studying. And the thing about hypoglycemia, low blood sugar, is there are lots of other ways that you can deal with that as well. And so often, usually in MCM, when people's blood sugar is dropping very low, it's overnight or once children or adults haven't eaten for a long time. And there's often simpler things you can do to prevent that with modified carbohydrate feeding. And even sometimes people have had small feeding tubes just during childhood, which means they can get some extra food dripped into them overnight. That's something I've seen a few times, which means that you have to have a small procedure to put a tube in your stomach, but it means you can simply be treated with a little bit of extra carbohydrate at night, which doesn't involve any medicine, which is experimental with side effects. So I think you could get it if the hypoglycemia was really, really difficult. But I think one of the reasons why it might not be possible so much is because there's other safer things that we can do for that particular complication. But if that's a big problem, please drop me a line, or anybody could drop me a line, because hypoglycemia is one of the things I work on a lot.
Is there anything you'd like to add to that, Ralitsa, at all?
No, he's the expert on that one.
Okay, there is another question. Wilma, would you like to ask your question?
Yeah, so it's an easy question. I was wondering how many patients with facial infiltrating lipomatosis do you know in the UK, or do you see maybe?
So so I've got a sort of funny situation that I see more of the people with sugar problems than with overgrowth problems these days. But we spent a lot of years trying to find as many people as we could with PCA problems, and we studied about 400 people. And goodness, in the UK, I can probably think of 4 or 5 children in particular with very, very large overgrowth of the sides of their face, and then many more people with smaller degrees of overgrowth. And that's probably a fair reckoning.
So with overgrowth, you mean lipomatosis, right? Not lymphatic.
Often it's a mixture. So often there's quite a big lymphatic component to the facial overgrowth. But again, it's this old thing that it can be anything. So it could just be fat. But oftentimes when you get the most growth, it's a mixture of fat and blood vessels and lymphatics as well. But around the world, there's a lot more patients known.
So in the UK, you would say 5 severe, and then maybe a few more less.
And then maybe a lot more are less severe. But you know, I would estimate we're talking about several tens would be my best estimate. So.
Thank you.
Okay, I think you already answered the last question. So we have about 5 minutes.
Except for the thrombosis, maybe didn't address that. But if anything, the PIK3CA defect. So basically, the question is, does alpelisib increase the risk of thrombosis and infection? So I mentioned the infections, but I think in terms of thrombosis, if anything, people talk about the PIK3CA defect increasing the risk of thrombosis. So if you then give alpelisib, that should have the opposite effect. But it's not the side effect that I've come across really in cancer studies either for thrombosis and alpelisib, but Rob might know more.
Yeah, I think one of the reasons for using alpelisib is to reduce the risk of thrombosis.
Exactly.
Because the things so when you've got abnormal blood vessels in PROS, the 2 types of complications you get from that are either bleeding in fragile blood vessels or blood clots in big baggy blood vessels. And so what the alpelisib does is hopefully shrink down those big baggy or fragile blood vessels. And in fact, in a lot of the studies now, people are doing blood tests to measure how much blood clotting is happening underneath. And you can see that it's reduced. It's one of the best things that's reduced on alpelisib treatment. So no, I think it's the other way around. Alpelisib is very good for that.
Okay, we have a few minutes left. Does anybody else have any question you'd like to ask Robin Ralitsa?
Very good questions.
Can I ask a question quickly? So going back to what I asked, so how would I even know if she was to have PIK3CD, is it? Would that have come up on her genetic testing?
Well, it depends what testing was done.
I think it was just a sample of tissue to basically find out if she had PIK3CA overgrowth.
So with the types of testing she's likely to have done now, no, it wouldn't. But honestly, the
disease is very different.
The chances of having both those things are almost zero. They're vanishingly rare. If she was having repeated severe chest infections, it would be worthwhile asking about that possibility on its own. It's much easier to test for that because the gene change happens in all the blood cells, so it can be done just on a blood test. It's not like PROS where you tend to have to take a biopsy most times.
Yeah.
So I think the chances are almost zero. But
and there would be other symptoms as well. No, I mean there would be enlarged lymph nodes and all sorts of things.
Yeah, no,
this highly unlikely.
The thing that I said to my doctor, that she's got quite bad bruising and things like that, and there was a lot more going on than what I'd actually realised as a parent. And with the amount of chest infections that she is getting, I was quite, unsure on whether, it was PIK3CA related, and it was just something that, she would possibly grow out of, or, if she having, I don't know, a flare up, something like that. But there's no harm in asking, when we see somebody next.
But it's much more likely to either be completely unconnected or to be connected to PIK3CA rather than the second gene. So although the PIK3CA doesn't change the immune system, for example, and I don't know anything about the scans or anything like that, one of the reasons you could have more chest infections could be if you've got a little bit of slight blockage of one of the airways, and maybe you could have a little bit of overgrowth partly doing that, so you can't clear away the bugs so easily. So not because the immune system is bad, but because of where the overgrowth is. It's not impossible that is related. So, but I think that's the thing to ask about, rather than a completely different separate condition. Which
okay, no, that's brilliant. Thank you ever so
7
much.
billion people, you never get two rare things at the same time, but nearly always you don't. But,
yeah, no, without a doubt. Thank you.
I think we've got one final question from Wilma, so fire away.
Yeah, I just came up with another question. What do you know, or do you have any updates about people who have 2 gene mutations, for example, PIK3CA and, for example, KRAS or whatever? Do you see this often, or?
I think I only know of one case, potentially, no?
No, there's a few cases around. I mean, I think it happens sometimes. The sort of situation, and I probably know of 5, 6, 7, 10 cases. And what I've usually seen in those settings and what's described in scientific papers is that there might be an area of a birthmark on the skin. And then within that area of birthmark, you see another little lump appearing with slightly different look to it. And then when you do the genetic studies, you see that, for example, the birthmark area had a PIK3CA change, and then there was a KRAS change or a GNAQ or a GNA11 change in the other bit. So just occasionally you can get 2 of these rare things happening together. And there's a lot of people studying this at the moment. I don't think it's very common. But yeah, it does happen. And we've seen that probably 3 or 4 times in the UK, I would think.
I heard the same in the Netherlands, about 3 cases, and I'm one of the 3.
Yeah, so
I'm always curious to know how far they are.
I mean, so it might be that because you got a little bit too much cell proliferation because of the first change, you increase the chances of the second change happening. So yeah, I mean, I think it's even possible that it's a bit more common than we think, but people are aware of it and are looking for it now. And as you say, there's probably several tens of people internationally who have been described in the literature already.
Thank you.
I just have one more quick question, if that's okay, Mandy.
Seeing as it's you, go on. As long as Rob and Ralitsa are okay to answer the last one.
It's just to Rob, actually. I was having a conversation with Mandy a couple of weeks ago, and I didn't actually know because that Vicky has now left Cambridge. So I'm just wondering what's going on there and what's happening.
No, Vicky hasn't left Cambridge as far as I'm aware. Unless
I thought, you know, the part, sorry. Right.
But she enjoyed running the sirolimus study so much, she ended up being one of the doctors who works not for the company that makes alpelisib, but a different company based in Cambridge. So she's still in Cambridge, and she still does do a clinic where she continues to see some people with overgrowth. But she's also been away having babies, so there's been a bit of a gap. So if you very much want to go back and see her, I'm sure we can drop her a line and just get you put back on the books.
Yeah, because I know I was due to, because she'd just gone on, she was just about to go on maternity leave, and she was going to make an appointment with me for like the next year, and then of course COVID happened, so I've not heard anything. So, and then had the conversation with Mandy. So
it's a general rule for everybody in the NHS, you know, with all the best will in the world, administrative things go a bit wrong sometimes. And so if you think that you've accidentally dropped off some list, then you probably have, and it's worthwhile making a noise until you get put back on a list. But if you want me to drop a line to Vicky, then please just let me know. If you could drop me an email via Mandy or something, I can tee that up. So.
Okay. Yeah, Mandy, would you like to text? Because I haven't got the email. I don't think I've got your email. So
feel free to. Mandy can connect us up directly. Whatever works for you. So.
Is that all right, Mandy?
Of course it is. Yep, I'll be in touch.
Thank you.
Okay, well that's about all we've got time for. So thank you people for attending and sending in your great questions. But mostly thank you to Rob and Ralitsa for taking up your time just to give you our time. No, give you our time even. We really, really appreciate, you know, your support and everything you do for PROS and the PROS community.
Well, it's always been lovely to see some old faces and some new ones at the same time. It's been very nice. So.
Thank you. Thank you very much.
Thank you. Good night.
Bye.
Bye.
See you later. Bye-bye.
Bye.
Bye.